right, thank you very much, and thank you for allowing me to participate in this symposium. So we're just going to give you a brief overview about the endovascular intervention part. I know everybody loves coronaries and seen a lot, but this is one of the new evolving fields that's coming up, and it's always good to get a good idea of how it works. So no disclosures, nobody gives me money, but it's okay. So the question is this: why is peripheral arterial disease important? As you can see, as and how the age progresses, the incidence and the prevalence of PAD significantly increases, specifically after the age of 80. Since most of people are now living more than 80 years old, it becomes a significant problem in addition to the other medical diseases they have. It almost goes up to 25% of the population. So it is a big medical situation, and we need to take care of it. And this is just a data to suggest that what do you do if patients just have intermittent claudication? You don't treat them, let them live their life, enjoy it. You can see that the survival actually grows from 100 all the way down to 50% in 10 years, just purely mortality, just based on the progression of the disease. The MI incidence increases, intervention and amputation all have a trend towards increasing. So it is a significant problem which we need to take care of. And the same thing again, if you actually see data from ARC in internal medicine shows that PAD, the mortality is actually more than breast cancer. So it is actually more significant, just to highlight the importance of the disease. So what are the endovascular managements of PAD? We have new advances nowadays. We actually sometimes are doing better than the coronary part, even though I'm an interventionalist and my primary is coronary. We have drug-coated stents, bioabsorbable stents, flexible self-expanding stents. We have drug-coated balloons, and we have certain atherectomy devices which help us in the intervention. This is, if you have to get an overview of the lecture, this is essentially what this is. It just gives you a highlight of various devices from the self-expanding stents, covered stents, drug-eluting stents, flexible, and atherectomy to give an idea of how successful our intervention is. So if you can see, and we average around 70% success rate, which is pretty significant. The gold standard for PAD intervention is essentially just plain old balloon angioplasty, and it's shown that the patency rate at 1 year is just 43%. So if we add on this newer technology to our basic baseline, our patency rate jumps up significantly. So there's a lot of development going on in the treatment aspect. So let's give you an overview of idea of how the stenting in the lower extremity works. So first thing is the drug-eluting stent. It's a newer technology in the lower extremity part. The most significant of this is the Zilver PTX. So essentially, it's a nitinol self-expanding stent, and it has a covering of Paclitaxel. I know most of you know how coronary stents work, and Paclitaxel was the first generation in the coronary stent. So we are actually back to the basics with the PAD, and we're starting with the first generation in the peripheral arterial disease. So the drug concentration is 2 to 3 micrograms per meter square, but there is no polymer. We have issues with polymer and thrombosis. So this is just the uncoated stent, and this is just Paclitaxel-coated stent. So the data in animal models actually suggest that there is significant decrease in in-stent restenosis, almost by 48 to 51% in Paclitaxel stents as compared to bare metal stents. So if you can see here, it's hard to figure out, but you can see the intimal thickening is more in the bare metal stent at 180 days as compared to a Paclitaxel stent. So it is pretty significant use of Paclitaxel drug technology in the stenting part. And just to give you an idea, this was the largest randomized trial of Zilver PTX, where they compared Zilver PTX with just balloon angioplasty. And if the results with balloon angioplasty were not significant, they did provisional stenting again, so compare. So they had two arms, Zilver with PTA, and if PTA failed, they did another Zilver with bare metal. So the data is pretty obvious. The 5-year patency rate is actually 72% as compared to provisional bare metal stenting, which is just 53%. And the target lesion revascularization. So meaning that once we have fixed the vessel, what would happen if we have to go back and revascularize it? We don't want re-interventions in patients. We want to prolong the time duration where the patient comes back and we have to fix the problem of the blockage again. Then again, in this case, even though it might not be statistically significant, but there's a trend towards higher patency or decrease in revascularization as compared to the provisional bare metal stenting. Just going on to the bioabsorbable stents. This is a newer technology both in the coronary and the peripheral arm, and you can see so many stents in trials in their pre-phase in Europe and in the US. You can see there are more of coronary bioabsorbable stenting trials, but there are a few, the top 3, which is in the SFA strategy where they're trying to get into the technology of bioabsorbable stents. So the basic background of bioabsorbable stents is you have a bioabsorbable scaffold, which is naturally reabsorbed and fully metabolized. So it actually just goes away. And it has a bioabsorbable coating over it, which is the poly-D-lactide coating. And again, that's also absorbed. But in this case, we use the everolimus drug. In the previous Zilver PTX, we had the Paclitaxel. So we did evolve to the second generation, which is the everolimus, 100 micrograms per centimeter square, and it's a self-expanding stent. So the whole idea is to inhibit neointimal atherosclerosis and neointimal thickness, thereby decreasing the instant restenosis rate, hence increasing the patency of the vessel and thereby improving patient outcomes. This is just one of the trials to give you an idea they used in the SFA and the iliacs, and the mean lesion length was 35.7 millimeters. It's a smaller length, it's not that big. Usually when we talk about SFAs, you'll see 12 centimeters to 15 centimeters, even 20 centimeter lesion. So it's a smaller lesion, but it's a first phase trial. So the results, as you can see, are pretty good at first and 6 months, but the problem comes at the 12th month. Because of the polymer coating, there is increased, they've shown like 2.9% of thrombosis and 8.8% of target lesion revascularization. So it's still in the works. It's actually shown to be better in smaller vessels where the scaffold is matched appropriately to the vessel diameter. But other than that, it controls the neointimal proliferation. So the results are promising, but it's too early, but it's in the developmental stage. Hopefully we'll see some more positive results down the lane and clinical implication for it. Just talking about one more stent technology, which is a different. Remember, I told you in the Zilver PTX, there is no polymer coating. It's just Paclitaxel or the bare metal. In this, we have a biostable polymer matrix, which is right in the stent, thereby having a long-term release of the drug. It's pretty much like how the coronary stents are essentially made. They have a polymer coating which binds the drug onto the stent, and then the slow release, hence the patency and action of the stent is longer. So you can see the drug elution release is 85% in 1 year. So it just keeps slowly at the end of 1 year. And same thing, it's a self-expanding stents, and they took longer lesion lengths. It's almost like 20 to 200 millimeters, and the diameter was 5 to 8 on the Eluvia drug technology. And if you look at the patency rate, it's very good, 96.1% patency at the end of 12 months. Especially when we talk about PAD, the patency rate, like I said, for the balloon angioplasty is 47% on a general population study. When you go up to drug-eluting stenting, it comes down to 70 to 80%, but this is 96.1%, which is very promising. But again, the data has to be extrapolated to 2, 3, and 5 years to really establish its consistency and its efficacy. But the 12-year data looks great. Just to give you an overview how the drug-coated balloons. Now we shift from the stenting to the balloon, because most of the people, including me, believe in nothing leaving behind, meaning I don't want to leave any metal in the vessel if I don't have to. So drug-coated stent, I think my partner, Ray Lascano, is going to talk on the lecture, so I'm not going to go over it. But just one slide on it, it goes back to the use of Paclitaxel, which is, like you know, anti-proliferative mitotic medication. It prevents regrowth and then thereby increasing the efficacy of the arm. This is just one of these slides to give you an idea. There's a lesion before DCB or the drug-coated balloon, and this is after. Look how nice and pristine and streamlined it looks. Almost looks like there's a stent there, but it's all about the drug coating. So the drug gets absorbed through the intima, and then there decreases the neoatherosclerosis down the lane. So it's a great new technology with good results, and I think Ray will discuss the trial results in the next slide. Moving on to the flexible stent technology. Everybody knows stents are hard, rigid, tubular structures. So what happens when you have a problem in your popliteal or the common femoral or the hinge joints? You know, if you bend, you hear about stent fractures. And once the stent fractures, the chances of restenosis are higher, thrombosis are very higher. So somebody came out with this technology of saying, okay, what if it's a flexible stent? So what do you mean by flexible stents? You can see it actually converges and it takes the shape of the vessel itself and it bends. So what essentially this is, it's just a single wire, and it's woven in such a way that it actually forms like a mesh of a stent. So that's why it's a single wire technology, so it can bend, torque, and torsion without much issues. So that's why it's called a vascular mimetic stent, because it takes the conformations. So you can see in a still picture here, this is your stent. This is your knee, which is bent, and the supera stent, which is the flexible stent technology, actually can bend at the knee and take two curves without any problem. If it was a stiffer stent like any regular bare metal stent, the chances of stent fracture are much higher. So we can actually now stent in the no stent zones. We call these areas as no stent areas or no stent zones. So the data, like I was talking about, if you look at like the patency of the stents with fracture and without fracture, so without fracture, it's almost, I'm sorry for the slide, but it's almost 75% at the end of 18 months. But if you have a fractured stent, the patency really goes down way, way low. So it's very significant, p-value less than 0.001. That's why it's very important to have this armamentarium in your treatment if it needs to be done, and with good results. And just to give you an idea, the vascular mimetic stents, it can be used in dissection, provides scaffolding, it has decrease in recoil, and it minimizes the outward force. This is just to give you an idea. If I apply a 20-pound pressure, the supera stent, it's actually open because the vessel tries to close on, and there's so much tension and recoil in the vessel itself. So if you put a stent in and you apply 20-pound pressure, the supera, the patency is much higher, and it can take so much pressure. While in the regular nitrile or bare metal stents, their force or their ability to take that force or the pressure is much lower. So it's 4 times higher. So it's more compliant. It's called vascular mimetic, and it just there's increased patency. This is just to give you over a trial, which is a superb data trial, which was used in 264 symptomatic patients with either de novo, meaning first-time lesions, never been touched, or in restenotic lesions, mostly in the superficial femoral artery and the proximal popliteal artery. And you can see at the end of 1 year, the primary patency rate was 86.3% with almost 0 fractures. There was no stent fractures at that time. And same thing, when you go by lesion lengths, that's one thing that's always concerning to our endovascular/vascular specialists is, what if my lesion length is longer? If I have more disease, would the chances of patency go down? Yes, technically it does go down, but you want to minimize those chances. So in this case, if you look long lesions, which are like more than 12, which are like 126 millimeters, which is the 12 centimeter almost from the SFA to the POP, the patency rate is still 87%, which is very remarkably significant as compared to just PTA alone. So, and again, you go down to 30, if severe calcification is the biggest barrier in coronaries. Any vasculature, calcification is what really inhibits, what really worsens your long-term patency. So, and stent deployment. So if in severe calcified lesions, which most of the people have because they are either end-stage renal disease, diabetic, vasculopathies, at 36 months, again, good patency rate. So it's a very good technology if it's used at a proper site and the proper way. This is just to show you. So this is my superficial femoral this is distal popliteal. You can see the femur, the tibia, and the fibula. And you can see the popliteal is completely occluded. There is really no flow with some distal reconstitution right there at the anterior tibial or the distal popliteal. Here we put a supera stent in. And look, now we have 2 vessel runoff. The anterior tibial is here, the TP trunk is here, and the popliteal is open. So good patency, good flow can be used at the no stent zones or flexible zones like we call, and great data like I showed you. Let's switch over to atherectomy. So what does atherectomy mean? Atherectomy is essentially reshaping your plaque. Because you have a lot of calcification and plaque, before we deploy a stent in, and in order to make sure the stent or the drug-coated balloon really does its job, we want to modify the plaque. The way we modify the plaque is by using these atherectomy or drilling devices, like you do rotablator in the coronaries, is essentially the same translation of technology, but more options in the periphery. So there are like 4 or 5 different modalities present, which are FDA approved in the US. One is a CE mark, just released recently, the Pantheris. So either you can have directional, meaning that it cuts in one direction, then you pull it back, cuts in the other direction, so you can have control over it. The other thing is rotational, like a rotablator. It just drills like a big hole all the way down through the blockage or the narrowing, and it clears it out. And one technology is rotational plus aspiration, because the whole concern is when I do a drill, what's going to happen to all that garbage that we produce? The hypothetically, they claim that the distal embolization that happens, the size is just 2 to 7 microns. and the RBC size is 6 to 7 microns. So technically, it should get absorbed and it should not block your downward flow. But anybody who's done and used this, we'll see a lot of slow flow, no flow, reflow kind of phenomena even in the legs. And it becomes painful. Myocardium, you still dilate, it absorbs, it goes away. Legs is like an end, it's like a dead end. You just loop around and you're stuck right there. So the aspiration one claims that they are, in addition to rotation, they'll actually suck it at the same time by the Venturi effect, and then it'll work from there. I'll show you a quick picture. So this is the directional atherectomy. So what it really does is you take the catheter down, and this is the blade. So it's rotating at almost 10,000 RPM, and what the blade does, we open the blade up. This is your plaque right here, and it just scrapes. It just goes shh. So you can go in 4 quadrants, 5 quadrants, however you want to. So it actually scrapes it, and it pulls it right into this wall. So we lock it, we pull it back, and we can keep going back and forth in all the directions. So this is your directional atherectomy, like we call. Again, what we have to always, what's the clinical data on this? I mean, it looks very fancy, oh, nice device, we're scraping all the calcium. In coronaries, we can't do all this stuff. We can't scrape the plaque out, but in peripherals, we are more aggressive and we can do it. But is there a clinical implication to it? Does it really affect, or we're just spending all the money we have in the world and no clinical benefit? So to what's our clinical translation is, so the 12-month patency rate in the Silverhawk trial, which was the definite LE, actually shows that if you have lesions up to 10 centimeters, it's 83%. As in how the lesion length increases and the calcification increases, we already know the patency is lower. But it's still decently well, it's 67%. You obviously want it higher, but it's all about the evolution of technology. So good results with good patency rates. Again, the same thing, especially when you do for calcified lesions in different zones. When you do infrapopliteal, it's a lot higher than when you do fempop versus the all calcified lesion, which is 76% right here, sir. And again, so essentially this was the largest independently educated trial for peripheral atherectomy, and it shows that it's good long-term efficacy, 83% in the SFA in claudicants, 78% in the CLI, or critical limb ischemia patients, and 95% success rate in patients who have limb salvage. We're trying to save their limb. They have gangrene, resting pain, color changes, all that stuff. We try to save the limb. It works very well. Another technology for atherectomy is essentially laser, which all we do is the laser goes in and it just blasts out all your plaque and your thrombus or whatever it might have. And this comes really from the EXCITE trial. So laser's main clinical implication comes in patients who have instant restenosis. It is the only FDA-approved device for instant restenosis in patients in fempop lesion. And this is just to give you an idea of the results. So if you just do laser and balloon versus laser itself, at the end of 1 year, the probability or limb survival is much better in the laser arm as compared to just plain old balloon angioplasty. And the same thing with the randomization group where they just laser PT alone. Again, the survival probability is higher in these patients as compared to PTM. I think I just repeated the slides. So like I said, it's the first FDA-approved device which is used in fempop lesions, specifically in the ISI, so the standard of care. Another technology to look at is orbital atherectomy. I'm sure you've probably seen it in the coronary arm. It's like a diamond grid coated stuff. So if you get it and if you have a chance to get out of the cath lab, just take it and go away. But if you're still working there, it's like a drill. I'll just show you the picture to give you an idea. So we take the wire down. This is how it works. So it works so it loops around. Instead of just drilling like this, it actually takes the shape of the vessel. So it does more of a looping around the vessel, thereby increasing thereby causing all the atherectomy to happen and then shaving off the plaque. One more technology like I was talking about is the aspiration. Remember we talked about atherectomy with aspiration? So this is by jet stream pathway. It works by Venturi. So it's like a drill, which pretty much goes like a rotor all the way down. But at the same time, you can see, it just sucks in, or it claims to suck in all the debris and the garbage, but thereby decreasing the distal embolization, hence decreasing the chances of having slow flow or no flow distally. So another great technology in hand specifically for long calcified lesions where you have to slowly drill and aspirate. I think it works great. And this is the latest technology. I don't know if you guys had a chance to see our live case the day before on Wednesday, where this is an atherectomy device, but here you can actually see the vessel wall. So it has an OCT. So what we do is we can see the layers of the vessel. You can see this is your plaque. It's hard to see, but your external elastic lamina is here. And so what it does is, and this is the balloon. So what it does is we inflate the balloon up. The same blade actually goes closer to the plaque, and you can cut it wherever you can see. So in this case, you're not cutting the normal layer or the abnormal layer. So you're just cutting the abnormal layer. So we're trying to avoid dissections or trauma to the normal segment. So this is something we're seeing and doing. While rest of the devices is more of an angiographic appearance where you assume that the calcium is probably concentric or on light on the left. So another great help for us to do this stuff. Just to quickly go over, venous insufficiency also forms a great part of our endovascular intervention. It might not be the PAD, it might not be as fancy, but it's a big, big problem. And I'll show you why. The prevalence of chronic venous insufficiency, or like we commonly known as varicose veins, is 30 million. The people who actually get treated are just 500,000. So it's amazing the discrepancy between how much the disease is present and how much it is there. I'm just going to quickly finish up. But again, the indication, what we do is radiofrequency ablation, which is where a radiofrequency, let me show you the picture. So what we do is we create radiofrequency in it. So it creates heat, it closes on the vessel, and it just helps with the reflux. So what's going on is here, we put a catheter all the way into greater saphenous vein from your knee all the way to the greater saphenous. This is your GSV and femoral vein. And what it does is, like I said, it generates heat up to 120 degrees centigrade. It's just done purely on local anesthesia, no general anesthesia, no nothing. It's an office-based procedure, 15 minutes. We do. Success rate is significant. So it burns these segments. So this is your segment here, which generates all the heat, which is 7 centimeters. We burn, we pull back, we burn, we pull back. So it keeps coming back. See, it pulls back, we burn again, and it pulls back. So it's a great new non-invasive technology helping treatment with symptoms, and it's an outpatient procedure. Patients are actually walk in and they walk out, so it helps with it. So just to finish up, the efficacy is great. 1 year, it's 91.9%, and it's actually at 5 years, it's 94.9%, no reflux. So this is just an overview. I'm sorry I rushed you through this, but just an overview of how the PAD, meaning the arterial disease and the venous disease, both work and what we are trying to help treat it. Thank you so much.